And there we go. And what our second poster presentation is about is the interesting BFI journey of Brightshores Health System. And Heather Christie and Jocelyn Patton Odette are our presenters. So I'll give you an introduction first for Heather. Heather has worked on the Women and Child Care Unit at Brightshores Health System for 35 years. She presently is the unit manager and has previously worked as unit coordinator and as an RN in pediatrics, NICU, and labor and delivery. Heather is passionate about breastfeeding and she supports and promotes BFI with hospital employees and the leadership team. Her co-presenter is Jocelyn, and Jocelyn is a registered nurse, IBCLC, nurse educator, and policy writer. She has worked on the Women and Child Care Unit at Brightshores since 2013. Jocelyn teaches fetal health surveillance, NRP, and pediatric and obstetric emergency simulation. Jocelyn is BFI project lead at Brightshores as part of larger quality improvement initiatives. So that's my introduction of our two presenters. So I'll turn the table over to Heather and to Jocelyn.
Jocelyn, do you want to bring up our presentation?
Yes, I'm just sorry. I'm having some technical difficulties. Can you see that?
Yes. Okay. Thank you, Mark, for inviting Jocelyn and I to present Brightshores' journey to BFI redesignation. We have no disclosures. Some of the objectives we'll be discussing tonight are a bit about our background, our BFI history here at Brightshores, our redesignation journey, which includes our challenges and our successes, as well as our future plans and recommendations. To give you a little bit of background, Brightshores Health System, we have a level 2 birthing unit with a 2B NIC unit. We have approximately 700 to 800 births per year. We're a rural regional center, and we're about 3 hours or more away from our tertiary care centers. We have 8 OBGYNs, 5 pediatricians, which include 1 neonatologist, as well as 1 midwifery group. Brightshores Health System in Owen Sound is the birthing center for our corporation, which includes 6 hospitals. We are also a resource for 2 level 1 birthing units in South Bruce. A bit about our BFI background. Leadership was very insightful and saw the value of BFI. In 1993, we started our first breastfeeding clinic and hired our first breastfeeding lactation consultant. Brenda was a trailblazer during that time, and not only did she have a big part in the changing of our processes and our policies, but she has also had to change the culture in our Grey Bruce communities. Our initial breastfeeding designation in 2015. At that time, we were doing skin to skin at all deliveries as a standard of care. We started doing C-section recovery in our labor and delivery. We were doing skin to skin and breastfeeding in our recovery room. We did develop the original breastfeeding policy as well as changes to our formula contract. We're fortunate here at Brightshores that we do have a Women and Child Care Unit Quality and Safety Council, and we've had that for many years. We do meet monthly. It is a multidisciplinary team, and at that time, BFI is a consideration in any process or policy development or review. The challenges of our initial designation, of course, the funding, the cost is a big one. First, there is the cost of the assessment. the cost of the orientation, and the cost of the formula. Before BFI happened here, we received free formula from the formula companies. We also got many small freebies, which included tape measures, scale paper, nursing coffee cups. When people went home, they got free samples and coupons and advertising for the formula companies. All of that, of course, had to stop when we did our BFI designation. Physician support, we are very fortunate here that we do have a very strong physician leadership, which does believe in BFI.
We were due for BFI redesignation in 2020, and we had planned an in-person assessment, but that was delayed multiple times due to COVID-19. We went ahead and completed a fulsome self-evaluation using the BFI implementation guide. From an education standpoint, in 2020, we developed a standardized breastfeeding orientation checklist, and that was initially a COVID alternative to our 4 hours of in-person training with an IBCLC. But today, that checklist and self-learning package continues to be used, but we supplement it with 4 hours with our breastfeeding clinic nurse. A major clinical change that came out of that 2020 assessment were decreasing barriers to pasteurized donor human milk in our NICU. We reviewed all of our policies and all education materials for evidence-based practice, alignment with BFI guidelines, and inclusive language. We went over every document that could be related to breastfeeding, and we expanded the list of documents included in the scope of the BFI assessment. In this photo, you can see the 11-pound document submission that we made in 2020. So this was all of our outpatient education materials, including those that we would use for specific populations, all of our staff education materials, a copy of every policy, and a letter for each step describing in detail how we address the BFI standards at Brightshores, how we assessed ourselves, and what changes we were making. So we provided the BFI assessor with a lot of information in 2020, and we were awarded a temporary redesignation based on that.
Some of the challenges that, of course, we had were the COVID-19 pandemic. Our breastfeeding outpatient clinic was closed. We had some redeployment of staff. We had changing COVID-19 guidelines that happened to us weekly, daily, sometimes hourly. However, we were able to maintain our BFI standards at that time. We do believe that the visitor restrictions did hinder somewhat, just because it caused a lot of stress on our new parents when they were not able to have their family at the hospital bedside. The big challenge that we had was the pediatric surge post-COVID. We had our WCCU is a multi-unit, so we not only have obstetrics, but we also have pediatrics as well as the adolescent mental health unit in our department. So our WCCU staff were caring for postpartum dyads, while also caring for overflow of acute peds and mental health patients. Some of our more experienced nurses were the ones that had to take on a little bit of this load, leaving our less experienced staff with the stable postpartum patients. But everyone did acquire more acute assignments during that time. And we certainly did see, when we looked at our breastfeeding indicators, that during the pediatric surge, our numbers did decrease a little bit.
In 2024, we are now looking to complete the full redesignation process. So we started with a repeat of the self-assessment using the BFI implementation guide. Clinically, we integrated more milk sooner practices, including the provision of antenatal colostrum kits in our antenatal clinic. And we have again increased our donor milk accessibility, this time to all NICU babies, which aligns with the CPS statement on breastfeeding in NICU. We have a corporate open referral policy that now includes breastfeeding clinics, so anyone is supported to refer to our IBCLC. Our previous breastfeeding or BFI policy was owned by the Women and Child Care Unit, but in 2024, we have moved that to wider policy formats that apply to the entire hospital and were approved by larger committee groups. We have started a regular schedule of breastfeeding education, an online record of that education and attendance, and we've moved the breastfeeding orientation to our online learning platform. This is our public-facing breastfeeding policy. So we created this in collaboration with our public health unit, previous version in 2013, 2015. But in 2024, we have updated it to improve accessibility and inclusivity. One of the challenges we've faced with this most recent redesignation process has been around well versus at risk versus unwell babies. Hypoglycemia protocol is an example of this, where we obviously want to treat and prevent hypoglycemia while also supporting cue-based feeding and avoiding rules about feeding patterns. This is challenging work, but BFI standards absolutely do not prevent best practice for unwell or at-risk babies. And in fact, the BFI requirements and standards are best practice. We have the same HHR challenges as the rest of the healthcare system, including less experienced staff on average than pre-pandemic. As a relatively small hospital, we have staff working multiple areas. So the nurse who works NICU may be assigned to a well baby the next shift, and it can be challenging for that nurse to reconcile the approach to breastfeeding from those two different positions. An additional challenge that has increased since 2020 is the impact of social media. Our staff have access to education and other resources online that may or may not align with local standards or be affected by commercial influences. If you haven't yet, look at this WHO UNICEF report on formula company marketing to understand how families and healthcare workers, yourself, your staff, are targeted online by pervasive and difficult to recognize marketing. We don't have an outcome yet for our 2024 redesignation, but we anticipate a successful in-person visit from the BFI assessors in June. We already feel successful based on our self-assessment using Table 1 from the BFI guide, and we have a mock assessment planned for the week before the real assessment.
To talk a little bit about our stats, we pulled the data from Born from April 1st, 2023 to March 31st, 2024, using some of our breastfeeding indicators. So the first one we looked at was breastfeeding initiation, number of babies who receive at least one breastfeeding. So here at Brightshores, we're at 93%, very comparable to other neonatal hospitals, with a level 2B nursery at 92 and the rest of Ontario at 89.4. The second indicator we'll look at is the infants exclusively breastfed or fed human milk, maternal or donor, from birth to discharge. At Brightshores, we're 57.7. Other level 2B nurseries are 48.9. The rest of Ontario is at 44.2. I think one of the reasons why our rates are a little bit better is we started giving out colostrum collecting kits at our birth prep. So moms are bringing in pre-pumped milk, and we also have the availability to give donor milk. And as Jocelyn was saying, we have widened the criteria for that to occur. The final indicator we'll discuss tonight is babies who were exclusively breastfed or fed human milk from birth to discharge, or if they received any feeds other than human milk, this was because of a documented medical reason. You can see here we're at 81.3%. Other hospitals with a level 2B nursery are at 67%, and the rest of Ontario is at 58.3%. So you can see we're considerably higher than the rest of Ontario for that. We did drop during February during our pediatric surge. We dropped down to the low 70s. And so we are well aware that this has happened the last couple of years. So we know ourselves that we have to be very conscientious come the next pediatric surge to be sure to continue with our BFI standards.
Looking ahead to 2029, that's the next time we will need to redesignate with BFI. We feel ready to do it again. We have really built BFI into our routines in a way that makes it easy to maintain BFI won't end for us when the assessors visit in June, and we won't have everything perfect by then either. A few places where we see ourselves improving before 2029 include increased language accessibility of our BFI pledge, currently only available in English. We are working on standardized breastfeeding education for allied health staff. And we hope to maintain a program of regular in-service education that would include those allied health staff. And finally, we are planning to implement MNCYN's regional maternal newborn orientation program, which includes a significant breastfeeding portion. And MNCYN is the perinatal network for Southwestern Ontario. Recommendations that we have for others on the BFI journey. First of all, target processes, policies, and providers. BFI is not asking us to police parents, but to police ourselves and our practice. You do not need to force higher breastfeeding rates, but to eliminate barriers to breastfeeding. Get buy-in from frontline caregivers by emphasizing that BFI is best practice. It's not about breastfeeding alone, but also about evidence-based care, informed consent, and safety.
Be prepared to sell it to your leadership. They're going to ask why spend this money on assessments, on orientating staff, on paying for formula, giving up all the freebies and the cost of the donor milk. So why do it? Like Megan said, we want to promote lifelong health for the babies in our communities. So BFI is not a sprint, but a marathon, and BFI is an ongoing process, and we truly believe that it is a journey, not a destination. Does anyone have any questions or comments?
Yes, we have one question, a couple of questions. Have there been any challenges getting physician buy-in to BFI practices at births, such as skin to skin, immediate and uninterrupted